everybody. Hope you all are fine. Today we are going to start the descending tracts in the central nervous system. Out of these, today's topic is corticonuclear tracts in the CNS. Corticonuclear tracts. These tracts are the part of the descending tract system which are also named as motor pathways. They carry movement-related information from the upper motor neurons present in the cerebral cortex to the lower motor neurons present in the brainstem and spinal cord. Corticospinal tracts comprise roughly 1 million neurons and their fibers, which become myelinated usually in the first 2 years of life. Corticospinal tracts originate from the cerebral cortex but have got three separate destinations. First component is corticonuclear tract, including corticobulbar tracts. These fibers terminate on the motor nuclei in the brainstem and are divided into two parts as regard their mode of termination. First subgroup is corticonuclear tract, in which the fibers terminate on the motor nuclei of the cranial nerve third, fourth, and sixth in the midbrain and pons through interneurons. Hence, their termination is indirect termination. The second subcomponent is corticobulbar tract. These fibers terminate on the motor nuclei of all the remaining cranial nerves in pons and medulla directly without any interneurons. Corticonuclear tracts provide bilateral voluntary control over muscles of the head and neck except lower part of the face and genioglossus muscles of the tongue. Second component is the corticopontine tracts. These fibers terminate in the ipsilateral pontine nuclei, and the fibers from these pontine nuclei cross the midline and serve as a communication pathway to the opposite side of the cerebellum as corticopontocerebellar axis. These tracts coordinate planned motor functions of the body. Third component is the major component, the corticospinal tracts. These fibers terminate on the motor neurons present in the ventral gray horn of the spinal cord. And they perform functions similar to corticonuclear tracts, but for the torso and limbs. And their functions are unilateral as opposite to the major part of the corticonuclear tracts. Corticonuclear tracts originate from the giant pyramidal cells of beds located in the fifth layer of the cerebral cortex, meant for the face and the head and neck region of the body. They originate from number 1, Broca's area 4, the primary motor area, which is the main source. Number 2, Broca's area 6, the secondary motor area or the premotor area. Number 3, Broca's area 312, the primary sensory area. And number 4, an association area number 5. These cells are named as upper motor neurons. And one thing to remember is the size of the cortex involved in a particular movement depends upon skill involved and not the bulk of the muscles, such as face, especially lips, tongue, larynx, and hand, disproportionately have larger representation as compared to the trunk and lower limb, which has got smaller area of representation. Now, the motor homunculus is the mapping of the skill related proportional representation of human body regions in the motor cortex, and this is also named as neurological map. The corticonuclear tracts course within the corticospinal tract and pass through number 1. The fibers converge from the cerebral cortex to the internal capsule, and this area is named as corona radiata. Sensory fibers pass in the opposite direction and diverge to access the cerebral cortex. Number 2, the fibers become compacted in the shape of internal capsule which lies between thalamus and basal ganglia, and the fibers are located in the genu part of the capsule. Number 3, in midbrain and also the pons. The fibers are located in the medial part of the middle 3/5 of the crus cerebri. The fibers of the corticonuclear tracts start separating from the corticospinal tract and at the same time crossing at successive level to synapse with the interneuron. Hence, finally reach the motor nuclei indirectly, and they reach the cranial nerve nuclei of the third, fourth, and sixth cranial nerves. Fourth, in pons and medulla, fibers descend close to the midline and continue separating from the corticospinal tract and crossing at successive levels. They synapse directly with the motor nuclei of the cranial nerves 5th, 7th, 9th, 10th, 11th, and 12th. So the final termination is of the fiber is that they synapse directly or indirectly on the cranial nerve nuclei, which are named as lower motor neurons bilaterally, mostly, except a part of facial nucleus and a part of hypoglossal nucleus located in the brainstem. Now let us enlarge upon the termination of the corticonuclear tracts. The termination mode is divided into two: the indirect mode of termination and the direct mode of termination. In indirect mode of terminations, fibers descend through the medial longitudinal fasciculus and reticular formation and reach the nuclei of cranial nerves through interneurons bilaterally. Starting from above in the midbrain, they terminate on the oculomotor and trochlear nerve nuclei. In the pons, they terminate on the abducent nerve or the sixth cranial nerve. These indirect fibers modulate the activity of the lower motor neurons. The second mode of termination is direct mode of termination, in which the fibers synapse directly with the neurons of motor nuclei of cranial nerves bilaterally, except part of the facial and part of the hypoglossal nerve nuclei. Efferent signals They convey efferent signals directly to the muscles of the face and head and neck. These nuclei are located from above Number one, in the pons motor nuclei, out of which first one is the trigeminal nuclei, which receives the bilateral input and controls the muscles of mastication. Second nerve is facial nerve, whose motor nucleus is divided into two parts: a dorsal region which receives bilateral input and innervate the muscles of upper face, and a smaller ventral region or part which receives contralateral input and innervate the muscles of the lower face. In medulla oblongata, the first nerve is the glossopharyngeal nerve. The motor nucleus of this nerve is represented by cranial part of nucleus ambiguous and innervate the stylopharyngeus muscle. Second nerve is the cranial accessory nerve. The motor nucleus of this nerve is represented by caudal 1/3 of the nucleus ambiguous and innervate the sternocleidomastoid and trapezius muscles. Third is the hypoglossal nucleus. The motor nucleus of this nerve is again divided into two parts: a smaller part for the genioglossus muscle, which receives contralateral corticonuclear input only, and a larger part for rest of the tongue muscles, which receives bilateral corticonuclear input. Last one is the vagus nerve. The motor nucleus of this nerve is represented by middle part of the nucleus ambiguous, and the nerve innervate the muscles of the pharynx, larynx, and the soft palate. The clinical relevance of the corticonuclear tract. Unilateral lesion of the corticonuclear tracts above the level of the cranial nerve nuclei usually do not produce any clinical effects on the muscles of the head and neck region. Reason being, cranial nerve nuclei, lower motor neurons, which are present in the brainstem, receive bilateral corticonuclear input. But there are two exceptions. Part of the facial nerve nucleus meant for the lower part of the face and part of the hypoglossal nerve nucleus for the genioglossus muscle receive unilateral input from the contralateral upper motor neurons only. Upper and lower motor neurons involving the facial nerve and their differences. First, the left-sided unilateral lesion involving the upper motor neurons. In this type of lesion, number one, the upper part of the face movements are not affected. Reason being that the dorsal region of the nucleus meant for upper part of the face receives bilateral upper motor neuron input. Hence, the forehead muscles are spared and the patient is able to wrinkle his or her forehead. At the same time, right eye is closed as the left eye. Number two, lower part of the face shows weakness of the movements. Reason being that the ventral region of the nucleus, which is meant for the lower part of the face, receives contralateral input only. Hence, lower part of the face shows muscle weakness in the shape of right corner of the mouth is pulled to the left by left-sided normal muscles. Second lesion, right-sided unilateral lesion involving the lower motor neuron. Number one, ipsilateral. There is ipsilateral total loss of the movement, that is on the right side. Number two, right side of the forehead is wrinkle free. The patient is unable to wrinkle his her forehead on the right side. Number three, right eye is wide open. The patient is unable to close, hence watering of the eye occurs on this side. Number four, right corner of the mouth. Number one is pulled to the left by the left-sided normal muscles. And number two, this corner is not properly closed because of the weak muscles. Hence, there is salivary flow from the right corner of the mouth. In case of hypoglossal nerve, as we already know that number one, a small part of the nucleus for genioglossus muscle, which is responsible for protruding the tongue, receives contralateral input only from the upper motor neurons. Number two, the main part of the nucleus responsible for all other tongue muscles, both internal and external, receive bilateral input from the upper motor neurons. Hence, in right-sided unilateral lesion of the upper motor neuron, because of weakness of the left genioglossus muscle, the right-sided normal muscle pushes tongue to the left. And in left-sided unilateral lesion of the lower motor neuron, because of weakness of left genioglossus muscle, the right-sided normal muscle pushes tongue to the left. The left-sided unilateral lesion of the lower motor neuron, that is hypoglossal nerve, may accompany the Horner's syndrome. This is in the shape of a triad. There is drooping or falling of the upper eyelid, that is partial ptosis. Then there is meiosis, that is relative constriction of the pupil. And number three is loss of sweating of the head and neck region, that is anhidrosis of the head and neck region. Reason being a disruption in the sympathetic nerve supply, and that is because of proximity between the sympathetic trunk and the hypoglossal nerve itself. Comments and suggestions will be welcomed. Thank you for listening and watching.